I'm going to take a few minutes. I think we'll finish the session on time. And I thought I'd pose a few cases of some common situations that many of us may see and get your opinions and get some discussion here for the audience. So, simple question, operative or non-operative for the clavicle? Dr. DeLong. So you kind of have this glenoid fracture as well, but what do you do with the clavicle?
Well, this looks like a right side. He's right-hand dominant. Everybody is. Very few of us southpaws. The glenoid fragment, I'm not concerned with. Looking at one view on the clavicle, this looks like a mid-shaft injury that is really not displaced. And I would treat this conservatively. I'd put him in a sling and treat him that way and let Mother Nature take her course.
I would first ask, has this patient ever had gravity x-rays? Not with weight, but was he standing up? Because you have someone with their arms down. A lot of times in these polytraumatized patients, they're laying on the x-ray table. They have their arm against their body, and you can't see whether or not there's true displacement of the clavicular injury. This isn't a true floating shoulder. It's not a scapular neck fracture. However, if he were to have stood up and their arms would be down and his clavicle would displace, then that would impart instability, and I would consider fixing the clavicle in that standpoint. I'm a little more concerned about someone who's 54 and mountain bikes with a shear fracture of his posterior glenoid. There's a fair amount of articular step-off, but it's a small, he is congruent. You could certainly treat it non-surgically, but I'd like to see different films of the clavicle to see if it imparts any instability before I consider treatment.
So one of the good points you made that I'd like to echo is something I was teaching about a year or two ago, and I've haven't mentioned this for a while, at least to my residents, is that there was a paper not too long ago in which they looked at in polytraumatized patients, we often underestimate the displacement because you're getting supine x-rays, you make a decision on how to treat the patient, they're in the hospital, and then they come back to your office 2 weeks later, and it's actually a pretty displaced clavicle fracture if you get an upright film. And thought being that when we want to truly assess a hospitalized patient for a clavicle fracture, once they're out of the ICU, and it's usually not something you have to do urgently anyhow, but before that patient leaves the hospital, maybe get an upright film and get a better assessment. Is this really a fully displaced fracture or not? So I think that was a good point you made up. Well, what if he had a glenoid? You kind of mentioned, well, it's a glenoid, but what if it's like a displaced glenoid neck fracture? What about this whole concept here that we learn about, this double break thing? Is that really an issue?
Yeah, for me that changes the game. When you have a quote-unquote floating shoulder, I think serious consideration should be given to fix both sides of that. If it's a dominant arm, and the patient is an active young person, different in someone that's 84, but that definitely gets surgical consideration.
Jack?
I think historically with floating shoulders, they would think about fixing the neck and the clavicle. Ling and Lam published on 16 patients where you could treat one or the other, just the clavicle fracture. And there's also been some studies that have shown if there's no instability of the clavicular fragment and not a lot of medial displacement of the neck or injury to the glenopolar angle, you could actually treat some of those conservatively without surgery as long as they fell under the criteria of not having instability at one or the other injuries. So there are studies out there that have shown you can treat non-surgically or just treating one, meaning the clavicle itself, based upon stability of the injury.
Sure. Question is, why wouldn't you fix the glenoid fracture? It's not congruent. Sounds like there's controversy because heard something else up, I think, Dr. Kazanjian.
Well, I think that's, I would look at other views and understand that fragment size. I think that's within acceptable limits of position. If it proved to be unstable, I would study it several times, and if it moved, then I would go after it. But I think, if it stayed right there, I think that'd be very functional and susceptible to the same amount of post-operative traumatic arthritis as, equal to what it would be if you treated it conservatively.
Disagreement. All right. What about this case? 32-year-old female, closed fracture, no skin tenting, non-dominant hand. What does the panel think? I'm not going to give you any more information. Just what do you think of that? Operative or non-op?
Like I said, you're not going to give me more information. I want to see better films. Is it posteriorly displaced? Does it spring up when she brings her arms down? She's a female, which also plays into other things, cosmetically, what they tolerate. She's a fashionista. I know I've been brought in Ontario or brought in Tioga. They might not want to have a scar. They might not want to have a bump. Not that that factors in decision making, but I like to see different films to see the personality of the injury.
Okay, well and I'm going to actually just show, and I'll ask Dr. DeLong now, does this change your, and I think it's a really good point. So that, a lot of times we get an x-ray and it's like, and this is the same x-ray series. I mean, you get an x-ray, you turn the patient, the fragment's moving, and a lot of times when we get x-rays on clavicle fractures and you're looking at it and it doesn't look so bad, and then it's not even the next visit. It's just sometimes you just get another view and you're like, okay, that's, on the apical view it looks a lot worse, or on this particular view it looks like all of a sudden it's grossly shortened and displaced. Dr. DeLong, does this change your decision?
Certainly, and clavicle fractures are very dynamic. When they're associated with they're isolated injuries or associated with polytrauma, this is something you have to watch very closely. I like to watch them at 1 and 2 weeks after the injury to make sure we don't get a change in position. Jack made a very good point here. You do have to see more than one view, and this is not acceptable, and this is something that I would encourage a patient to have fixed.
How do you guys assess for shortening in a comminuted fracture or something? Do you get contralateral views? Do you just make the assessment on the available views that you have? And is there a number or criteria that you use when you start to say, it's too much shortening?
I have not gotten contralateral views in acute cases. I've done it for non-unions. I've used 15 millimeters of shortening based upon some of the data. 15 millimeters of superior displacement, 15 millimeters of shortening as a relative guide to surgical intervention in the patients. This patient's got bayonet, but you still don't know if she's posteriorly. I've had myself saying, I think that they're substantially shortened, and I've gone on and I've fixed patients, and once I've been there intraoperatively, I've noticed that it wasn't as short as I thought it was. It was just more of a long oblique type fracture. So for me, it's more of looking at the patient, looking at the x-ray that I have. I don't get contralateral films because I've been fooled thinking that there's more shortening than there was based upon the obliquity of the fracture lines that have presented to themselves. So
yeah, it's amazing.
I use 15 millimeters.
To me, I think, we get plain films and make management decisions. We have patients in the OR and we're getting surprised by stuff. I mean, it seems to me like, if you could easily get a CAT scan and 3D imaging and be able to do this in an office setting easily, I mean, it would eliminate, I think, some of this guesswork. Dr. Schaefer.
Yeah, just a quick one, and it's back from a long time ago when I did actually treat some of these, but for the panelists and the moderator, after you operate on one of these, when do you tell the patients they can be active? And just a short story, I had a series of some jockeys from Philadelphia Park that would have these, and Dr. Lockman taught me that these all healed and that they only didn't heal if you operated on them. So I didn't treat anybody with surgery, and those jockeys only earned money when they rode, so they were just every visit asking me, when can I ride? And if you fix them, when can they be active?
It all depends on what activity they want to get back to. If it's a jockey who's going to get thrown from their horse, or I tell them it's 3 months. I tell all my collision sport athletes, or my athletes that are highly involved in those types of sports, that it's 3 months, because once you get past the 3-month point, the risk of refracture substantially decreases. There's been some reports of professional football players, Patrick Connor in North Carolina, who has gotten them back at 8 weeks, and they've all had issues with refracture. So I hold steady to all of my athletes and patients that are fairly active that at 3 months you can go back to contact and collision sports. If they show a significant union and callus at 8 weeks, I start letting them do some light strengthening of the upper extremity, and I am fairly more conservative in my initial post-op course with these patients, because if you tell them, have at it, go as is, take your sling off, then they're going to come back doing a lot more than they should. And I've seen some patients go on the delayed union due to the fact that they've been a little bit more aggressive than I would like. So the first 6 weeks I take them fairly conservatively. I don't really do any physical therapy. 8 weeks, a little light strengthening. 3 months, I let them do whatever they want to do.
You saw the paper that used CT scans to evaluate healing, showed that even the operative cases only had 82% healing at 12 weeks. I pushed this 4 months, and for contact, I'll push it to 5. Want to make sure that it's a one-time operation and they get the best function back that they can have before you expose them again to another injury.
It's one of these where I think that your anecdotal experience is at odds with the literature, and you really have a hard time, but the literature's clear. And I didn't do dash scores, I didn't check their strength, but when he didn't hurt, when he could use his arm, I couldn't tell him, and actually it was his wife, that he's got to ride because we got no money coming in. I let him ride, and I let a guy ride at 4 weeks because he had a big lump of callus. He didn't hurt, and he had a strong arm. So,
yes, last question.
So 85 to 90% of these heal, and non-union does not mean poor function. Some of these are elderly, so if they're down and dirty, agreement is on the personality of the patient, and the fracture, is it a diameter displacement, is it shortening of 15 or 25 millimeters? I mean, what can you give us for your indication?
If you look at the Canadian literature on diaphyseal fractures, 85 to 90% do not heal. It's a certain subset that doesn't heal. It's up to 30% non-union rate. And what they found in the certain subset, Z fractures, those with 15 millimeters of displacement, 15 millimeters of superior displacement, butterfly fragments, those patients are the ones that are at risk. Those are the ones that if you treat non-surgically, they can have an increased risk of non-union up to 30%, increased risk of fatigability doing overhead activities, shortening of the extremity, which can cause difficulty with strength overhead. So if you're looking at the subset that's at risk, it's the middle third fracture, the Z-type or Z-type fracture, large butterfly fragment, 15 millimeters of shortening, 15 millimeters of superior displacement are the ones that are at risk. So that's the ones that I gear towards surgical intervention. I give them the data. I let them make the decision.
I do something similar. I would encourage you to stay away from a lot of CT scans for this, because I think that's a lot of radiation, and most of these are young people. Using the other clavicle and just measuring right on your electronic radiograph is one way to do it. I start looking at this at 15 millimeters and looking at the patient's situation. But in the overall scheme of things, there's no question about the Z injuries. That they have got to be treated, and you've got to try to do your best to avoid that significant disability that we now know can occur if these go untreated.
All right, I'd like to thank the panel. I do want to move along, and certainly if anyone has questions,